Hi, good afternoon, everyone. Thank you for attending on a weekday at 5 o'clock. We welcome all of our patients, the New York Presbyterian community, and those who might have received the invitation externally. My name is Dana Lucan. I'm the clinical director for the Jill Roberts Center for IBD, and I have the honor to be joined by my colleagues, Dr. Randy Longman, who is the director of the Jill Roberts Center for IBD. And we have the chief of colorectal surgery, Dr. Alessandro Fischera. Today, we're going to be discussing the IBD program at Cornell. I'm going to first give a general overview of inflammatory bowel disease, followed by a little bit of the basics of concepts of how we treat and some of the medications that you may have heard of that are options for treatment. Dr. Longman will then go on to discuss some of the principles of clinical trials and the infrastructure which we have built both from the medical and surgical side for performing clinical trials and enrolling in clinical trials at Cornell. And then Dr. Fischero will talk about some of the really fantastic surgery aspects and services that are available through Weill Cornell. And then we'd like to leave a lot of opportunity for questions and answers. Please feel free to enter any of your questions into the Q&A box, and we'll get to as many of those as we can. Just remember that there are a large number of registrants here and people that are in the audience, so please refrain from any personal details or anything that you wouldn't want to be shared publicly. And with that, I'm going to get into the first slide. So when we talk about inflammatory bowel disease, we're talking mainly about two conditions, Crohn's disease and ulcerative colitis. These are distinct bowel diseases that are characterized by similar levels of chronic inflammation. We believe that they are related to an underlying genetic predisposition, meaning the distinct combination of genes and uh, other inherited characteristics make it possible to have IBD, but we also talk about a complex interplay between the immune system as well as the intestinal microbiota, or the bacteria, viruses, and fungi that are living within the body, and other environmental triggers which turn on and on switch of inflammation that is characterized by a waxing and waning, or periods of activity and periods of remission for both of these diseases, and ultimately the potential to cause some complications of chronic inflammation and other things which we'll talk about. Crohn's disease can involve anywhere in the digestive tract. This can start in the mouth, all the way down through the digestive tract, through the both the small or large intestine, as well as extraintestinally. Whereas ulcerative colitis tends to be involved only in the large intestine or the colon. Hence its name. It is a much more superficial process that tends to always involve the end of the large intestine, called the rectum, and a variable involvement of the areas further up in the colon. And so we sort of distinguish these by, and we can tell, is this Crohn's disease or ulcerative colitis based on where it is, small intestine, large intestine. Is it continuous inflammation, as we often see with ulcerative colitis, or is it skip areas, which we tend to see in Crohn's disease? Because Crohn's disease is not only superficially causing inflammation, it can also lead to inflammation through the deeper layers of the bowel. And this can lead to complications that are manifested with a stricture, which is a narrowing, which can cause a blockage of the intestines, or an abscess or fistula when the disease process does go through the entire wall of the bowel and leads to a collection of inflammation called an abscess, or a connection from the bowel to another structure called a fistula. The symptoms can be very similar for both of these diseases, and it's very important that you do establish with a gastroenterologist to try and help you understand what's going on. If there are symptoms that are listed in the box, namely abdominal pain, diarrhea, and/or rectal bleeding, but a number of other of the symptoms that are listed can be present. So next slide. So just to talk a little bit about this relapsing and remitting or waxing and waning course of both inflammatory bowel diseases, this cartoon is to illustrate a few points. The squiggly line that you see is what you as a patient experience. These are symptoms that you might be aware of that say something isn't right. However, if you look at the shaded area, this describes some of the inflammatory changes that are going on within the body that may or may not lead to clinical symptoms. And you'll notice that even before the time of diagnosis, a lot of this inflammation can be present. And so it's really important that we understand what we're dealing with and do what we call a risk stratification to understand what type of disease each patient has. And what we aim to do is control the inflammatory changes before, as we get further and further to the right, where the multiple relapses or progression of disease can lead to these complications that I mentioned, the stricture, the fistula. And these are the things where we might need to call Dr. Fischera for surgery. And so certainly in Crohn's disease especially, the cumulative bowel damage may reach a point where it is less amenable to medical therapies. And so the earlier and more effectively that we're able to diagnose and treat, we hope to minimize these complications and prevent them from happening, and hopefully to reduce the need for surgery. Therefore, there's this window of opportunity early in the disease course that we hope to identify and treat, while the same stricture, fistula, abscess complications are less frequent for ulcerative colitis. The same principles do apply where we want to reduce risks such as precancerous changes, colon dysplasia, or colon cancer, as well as some of the functional consequences of longstanding inflammation for ulcerative colitis. Okay, next slide. So we generally try to focus on an approach that's called treat to target. And we've borrowed this from the rheumatologists who have been doing this for many years. We want to understand like I discussed before about a risk stratification. What is my patient's risks, and how do I most effectively reduce the risk that there will be complications? Using an approach where we sequentially try to go after different endpoints in different timelines is really helpful for us as clinicians to try and first achieve the thing that is most important to our patients, which is feeling better, and that's symptomatic response, which is feeling improvement, but also symptomatic remission, which means no signs or symptoms of disease. We look at things objectively like blood tests, the C-reactive protein, or a stool test such as a fecal calprotectin, which are very good indicators of whether or not there's still inflammation, regardless of how you're feeling as a patient. Once we've normalized those for our children who are affected by IBD, this often affects their growth. And so we hope to put them back on the growth trajectory. And ultimately, our guidelines do emphasize using that we will assess with a colonoscopy to make sure that inflammation that was present has healed. And that's called endoscopic healing. These things are obviously can't happen without all the first things happening. And that's why we now try to do these in a sequential manner. Achievement of these outcomes actually is associated with improvements in health-related quality of life and the absence of disability, meaning the impact of these diseases on patients living with them that prevent them from doing things that someone else their age should be expected to do normally, right? And these include not going out to eat, not being able to go to work because of disease-related symptoms, et cetera. And so our guidelines really have addressed that because they've listened to patients and they've listened to clinicians who are treating and understand that these are really the most important things to prevent complications long term. Okay. Lastly, I just wanted to mention some of the therapies. So when we think about our therapy for IBD, we can think about the prescribable medications, right, which I've listed here as aminosalicylates, things like antibiotics, but also understanding that a lot of people in the community also rely on diet, and we understand that diet is one of the risk factors for the bacterial changes in the intestine that may drive the development of IBD. And so a lot of folks talk about diet. A lot of folks talk about using other supplements that have been investigated for IBD. But when I'm talking about the prescribable therapies for mostly for ulcerative colitis, we have our aminosalicylates, which are mesalamine or sulfasalazine. Um, when we talk about antibiotics, there really is a limited role in ulcerative colitis, but certainly, and for Crohn's disease, but certainly for patients that have conditions like a fistula or an abscess, we may have a role. Corticosteroids, including prednisone or budesonide, are frequently used and often will work very quickly, but we also worry about the risk of complications with prolonged steroid use. And so while they're an option for initial therapy, we do want to find steroid-sparing options for those patients with more than mild disease. You may hear of immune modulators such as azathioprine, mercaptopurine, or methotrexate. And these have been used since the 1980s for IBD, although they are somewhat less common these days. Below the dotted line, you'll see the disease-modifying therapies, right? And these we call disease-modifying because we believe that with proactive and effective use of these medications, we can hopefully slow the course of the inflammatory process and prevent complications that might develop without these medications. And these are several classes which you can read here. Um, these are the biologics are antibody-based therapies, and they are highly effective and usually given by injection or IV infusion. And the small molecules are oral therapies that are usually daily dosage. And so all of these have been proven in rigorous phase 2 and phase 3 clinical trials to be superior to placebo, and in many cases, other therapies to lead to healing. So that's a very broad overview of some of the concepts of medical therapy of inflammatory bowel disease. I wanted to leave you a slide with some options and with some links, and you will be getting these slides emailed to you after the presentations are done. But just to show some links from the American College of Gastroenterology, a link to a Health Matters article that Dr. Longman and I did sort of a little bit of a deeper dive into IBD, and also to the Crohn's and Colitis Foundation, which is a tremendous resource for patients and to caregivers and other clinicians as well. So thank you for listening to my introduction here. I'm going to turn it over to Randy Longman, who will discuss a little bit about clinical trials.
Okay, thank you. Dr. Lucan, can you hear me okay?
Yes.
Wonderful. Okay, it is wonderful to see so many people attending this conference, and I really look forward to highlighting to you, which I think is really one of the unique aspects of the Jill Roberts Center, and particularly our approach at Cornell to treat inflammatory bowel disease. So as Dr. Lucan just went through, that although we have many good therapies for inflammatory bowel disease, unfortunately, they don't work for every person. And some people may need different types of therapies, combination of therapies, personalization of the therapeutic regimen in order to get them at a place, as Dr. Lucan was suggesting, to their targets. So what we're going to highlight here are really some of our participation in clinical trials for refractory disease. Refractory disease is a disease that doesn't respond conventionally to the medication off the shelf. And sometimes this needs some tinkering to understand exactly which medicine is required for which person. There are really a lot of benefits to being able to access some of this emerging therapy. And these are partnerships with researchers throughout the country. These are partnerships with pharmaceutical industries. And what we really aim to do here is to get this technology, to get these medicines, to get these therapeutic approaches to our patients as quickly as possible to see what can help patients. And so we really leverage our academic medical center and our scientific knowledge to be able to use these new therapies to bring them to bear in our patient population. And so I'm going to ask for the next slide. And so just to highlight, what are those therapies? And I would say broadly they come in three different flavors. One is new medicines. There are new types of biologics. There's new types of small molecules that can be very effective for the treatment of inflammatory bowel disease, and not just even more effective, but sometimes in some situations even safer than some of the medicines that we currently have. Also, we've learned that different people's immune system is different. While some people may respond to Remicade or some people may respond to Humira, other people may need Skyrizi. Other people may need Tremfya. So how do we know which person needs which medicine? And so that's a very active part of our research program. And in addition to that, we have additional medicines that we are partnering with pharmaceutical companies to test some of those medicines. And that really expands the therapeutic options for some of our patients. The second flavor that I wanted to talk about is dietary therapy. This has really been a mainstay of our therapeutic approach at the Jill Roberts Center since the founding of that. We've really felt that nutrition and dietary therapy is so integral as an adjunct for the treatment of inflammatory bowel disease. We have used this with several different approaches. One is specialized nutrition plans, and this includes a nutritionist who meets with all of the patients that come through our IBD center to be able to assess the dietary intake and to evaluate whether or not dietary plans would be more effective. We have different types of dietary therapeutic plans, which we are testing for the treatment of Crohn's disease. Dr. Lukin led a study looking at intermittent fasting for Crohn's disease. We've looked at different types of fiber supplementation in combination with microbiome therapies for the treatment of ulcerative colitis. And so we have many aspects to really provide patients with opportunities to expose them to therapeutic trials for dietary intervention. The third flavor that I wanted to talk about, and that I would say the Jill Roberts Center really is a leader here, is understanding the microbiome in inflammatory bowel disease. We know that there are changes in the gut microbiome that exist with inflammation, but the question really remains is how do we correct those? Can we give probiotics? Can we give prebiotics to feed some of these probiotics? And in some situations, can we even give a microbiota transplantation to help promote health? And these are active studies that are going on both for ulcerative colitis and for Crohn's disease. And please feel free to reach out should any of these studies be appropriate. And the next slide, please. Right, and so just to highlight here that it's a team approach. It really takes a village to be able to take care of patients with inflammatory bowel disease and really to have the privilege of taking care of patients with inflammatory bowel disease. We have 7 IBD-focused gastroenterologists, which are listed here. In addition, we have a nurse practitioner team that extends this coverage to allow us to give a very effective continuity of care. We have an infusion nurses that supervise our infusion suite, which is just adjacent to our clinic. We partner very closely with our pediatric colleagues, some of which are listed here. Melissa Stoffels is our nutritionist, and she works with all of our patients for inflammatory bowel disease. And so we really take a very integrated approach to treating patients with inflammatory bowel disease. And it's on that note, I would like to transition to Dr. Fischera, because inflammatory bowel disease is very much a collaborative approach. Dr. Fischera, please.
Thank you very much. It is now clear to all of you, I hope, why it is a great pleasure to be part of this team. The treatment of inflammatory bowel disease is a team sport. Surgeons alone cannot do it. Gastroenterologists alone cannot do it. And for us, having the support of this very talented group of individuals, both on the adult side as well as the pediatric side, and the infrastructure of nutrition and all the research behind it, makes it very, very, very stimulating, interesting, and exciting to work in the IBD center. Surgery as well, as I said, plays a significant role in inflammatory bowel disease, and it's important that we all understand that surgery, when a patient is refers to surgery, is not a failure. Surgery is one of the treatment modalities that sometimes can like in ulcerative colitis, cure the disease, or cure the symptoms and palliate the symptoms and improve quality of life, like in Crohn's disease. So we are all part of the same journey, as Dr. Lucan showed in that diagram at the beginning of the presentation. So it's a process. And as was said by the other two speakers, this is a team effort. The gastroenterologists are the front line, if you want to call it that way, and they really are the people that establish that relationship with the patients. They're the one that see them when they get diagnosed. Very difficult time. I can only imagine how receiving a diagnosis of a chronic disease like Crohn's or ulcerative colitis, the impact that could have on a teenager, for example. And they become sort of the people that help patients go through the entire journey. As I said, surgeons, we are part of the treatment team. We are not a failure. We're not, when you come to us, it's not because we have failed, it's because the time has come for a different medication, a different approach, a different way to treat the disease. Obviously, we talked about dietitians, and oftentimes there is the need also for some mental health professional. This is a chronic disease that impacts not only the patients but also the family that supports them. I think I found in other institutions where I was before, I found that regular teams meetings are essentials. Managing these patients requires close collaboration, communication, and our monthly meeting is when we share the new patients, and we discuss the approaches, we brainstorm, and having such a big group, both on the GI side as well as the surgical side, I will show you the surgical side soon, it's very helpful. Patients in inflammatory bowel disease are very knowledgeable, very involved, and so are the families. One of the first questions I ask when a patient with inflammatory bowel disease is referred to me is, what do you understand of your disease, and what really would you expect me to help you with? And now that you are seeing the surgeon, because patients are really involved, educated, and want to be part of it. And it's also shown by the high number of individuals that joined this webinar on an afternoon, a beautiful day outside. We've had more than 120 people participate. So this is great. And now with what we learned during COVID, the use of telemedicine will facilitate regular communication with patients, with each other, and improves the access to care that our patients have. Let me go to the next slide. There are some very important pre-surgical considerations. Patients usually come to us for the majority of times prepared for what is next. Right? We have in surgery we are blessed to have such a talented group of gastroenterologists. So the patients come prepared not only psychologically, mentally, but also optimized as much as possible from a general health perspective. More comorbidities, nutrition, and other factors are usually at their best state considering the chronic disease. There is still room for nutritional optimization. That is why we have nutritionists involved with the care of these patients. A chronic condition tends to create especially during flares, a state of malnutrition, poor nutrition. Medications have some side effects, so we need to also optimize them in preparation for surgery. We do know more and more about the potential side effects as it pertains to surgery of most of the biologics agents or the small molecules in this day and age. It was very different when we started using them. I think now we do know how to manage in the perioperative period. Smoking cessation is another big one for us. Smoking is associated with a higher risk of complications in general when you do surgery in general, but even more so in inflammatory bowel disease. Smoking cessation is another big one, and then improve physical and mental health in preparation for surgery. Oftentimes, you don't have the time to do that, as the patients come with a more urgent condition and needs attention in the immediate future. But sometimes you have that time to encourage physical exercise and provide psychological support when indicated. At some point, I will learn how to advance the slides eventually. Now, when we meet with the patients, again, we are fortunate to have a group of people that refer patients to us at the right time with the right mindset and right indication. But there are some priorities that we discuss with patients, and especially in Crohn's disease, where the surgical treatment is aimed at improving quality of life. It is important to understand the current state of quality of life and the expectations for quality of life. We discuss in surgery very often the risk of recurrence after surgically induced remission. Is something that patients, especially with Crohn's disease, are very aware and very concerned about it. We do know that some of the newer surgical approaches, like the convalescence and anastomosis, as well as the more effective medical therapy, has decreased that risk of recurrence. And the fear in the past that surgery was just opening a can of worms and then it was going to be one surgery after the other, that's not really the case anymore. We are well aware in Crohn's disease, especially, how important it is to preserve intestinal function. We do have here at Cornell with some of our faculty members one of the largest experience in strictural plastics, for example, which is a way to preserve intestinal length and maintain intestinal continuity. That's what I meant by intestinal continuity, preservation of defecatory function. A defecatory function that has to be meaningful, right? You want to have control of your bowel movement. You want to have a manageable number of bowel movements per day, and that is a balance between aggressive surgical treatment, control of disease, and preservation of defecatory function. Preoperative optimization also decreases the risk of postoperative complications, which is also something our patients are well aware of. And while no surgeon has zero postoperative complication, we do the best, we try our best with our gastroenterologist counterpart to decrease that risk. We use a lot of minimally invasive surgery to decrease the trauma to the abdominal wall. A lot of our patients are young. They have several decades of life ahead of them, so we want to decrease that risk of potential hernias down the road by using minimally invasive surgery. That also improves cosmesis after surgery. And I put it at the end, but that always comes at the beginning of our discussion, is the patient's preference. Preference not just in time, in terms of what surgery to do, but also when to do it and what can we do to optimize it. we have young individuals that are in school, that have a new job, so that there is a big component that needs to be covered when having discussions about surgery. And as I said, and this is our team of surgeons. We are 6 very talented individuals. The chairman of our department, Dr. Nicolasi, also does quite a bit of inflammatory bowel disease. I would say we have 7 very talented individuals that deal with inflammatory bowel disease. We are here to help, and we are here to work with our gastroenterology colleagues. And our last slide is the contact numbers. You will receive this presentation, so you don't have to take any notes or take any pictures, but this is the phone lines, our addresses. And while we are across the street from each other, we communicate extensively. We often send patients across the street to see each other when indicated. So with that, I will end the presentation, and I will open the discussion with Dr. Lupin and the chat.
Okay, well, thank you to both Randy and Alessandro. We've received already a number of questions, and feel free again to enter these into the question and answer box. So I will start with the first one, which is regard to does endoscopic healing refer to the visual appearance of the GI mucosa or the appearance of pathologic specimens, so biopsies? And so that's a great question. Our guidelines, including the STRIDE 2 guideline that I showed you there, actually focus on endoscopic healing, meaning that you should have no ulcers or visible inflammation on an endoscopy, but it doesn't take into account the biopsy findings, which is called histological healing. Many studies have started to incorporate histologic healing into their endpoints, and there may be additional benefits to getting the histology to show inactive colitis, for example, which may have additional benefits over the endoscopic healing, but our current guidance does not suggest that we need to go that deeply. We will probably see more about this in the next version, STRIDE 3, that may talk a little bit more about histological guidelines. There are some data to suggest that the achievement of histologic healing may further reduce the risk of colon cancer that is already seen with achievement of endoscopic healing. And so it's something that we don't formally go towards, but we are certainly happy when it does occur. Okay. I'm going to take one more question before sending another question to the group, and that was sort of a question about the IB letters, right? And so I always get this when I do a community webinar. And the question is, what is the difference between IBD and IBS? Okay. And so I'll also answer this one. So IBD stands for inflammatory bowel disease, and IBS refers to irritable bowel syndrome. Okay, and so the I will tell the difference here. I meaning inflammation, inflammatory bowel disease is all of the diseases that we've talked about that are chronic inflammatory diseases that lead to bowel damage through the inflammatory process. Inflammatory bowel disease has many of the same symptoms as IBS or irritable bowel syndrome, but is the set of diseases that is associated with a risk for needing surgery, for having other complications, and for using medications that often will work via modifying the immune system. IBS tends to be a non-inflammatory condition. There typically is not any blood in the stools. It is characterized by abdominal pain and frequently diarrhea, but could also be constipation. But pain is the hallmark of IBS. This is not something that is responsive to immune modifying therapies, and it is certainly probably the most prevalent gastrointestinal disorder and the most frequent reason why patients will see a gastroenterologist. there is an overlap, and this sort of hints on one of the other questions, which I won't directly answer, but that about a third of patients can have evidence of both irritable bowel syndrome superimposed on top of either Crohn's disease or ulcerative colitis. And so hopefully that answers the question to the uh, audience member. Okay. Um, all right. So Randy, maybe you want to touch on this question. It's a question about stem cell therapy for fistulas. Are we close to being approved? Are there significant clinical trials on this topic?
Yeah, great. I think it's a very exciting area, and Dr. Fischer also, may have some comments here. Different types of stem cells we've now seen that they have different types of healing properties. And this is a very exciting, still emerging area in how to effectively use these types of stem cells. Fistulizing disease has been one of the most complex areas for Crohn's disease. And, with respect to some of our medical therapies, the only ones that we really have good data for with some of the older classes of anti-TNF alpha. And so we're still very much struggling to try to understand what is the best medical and or surgical approach to this. And I think that stem cells have offered a bit of promise in some of the emerging studies that we've seen. Now, one of the more recent studies, was complicated maybe because of the study design, such that it didn't allow us to see the potential benefit of the stem cell implantation, potentially because the placebo approach was also helpful for the fistula. And so additional studies are currently underway in addition to, or including, I should say, studies that we're involved in at New York Presbyterian to be able to evaluate that. And Dr. Fischer, I don't know if you want to comment on potentially, your experience with some of these studies.
Great. No, that's probably the most challenging for the surgeons. The most challenging aspect of inflammatory bowel disease is managing perianal fistulizing disease. The impact on the patient social life and quality of life, sexual life are incredible. So it's a topic that we pay significant attention. Now, there are clinical trials on the surgical side using stem cells for non-Crohn's disease fistulas. There's a garden variety fistulas that patients get without any inflammatory bowel disease. And the difference between the two, and that's what makes treating fistulas in Crohn's disease more complicated, is that your chances of success in inflammatory bowel disease is also dictated by the luminal activity. If you have active proctitis, if you have active inflammation in the anal canal, it's very hard to get ahead of the disease or the fistula per se. So it's more complicated. In the non-IBD world, stem cells actually work quite well for fistulizing disease. So that I think is closer to being FDA approved in the US. The approval of stem cell for that type of use. For Crohn's, I think, as Dr. Longman said, the evidence is not black and white yet. So I think that will require a little bit longer, more studies, not longer, more studies.
Great. Just one quick question that I'll answer. How are these studies going to be affected by our government administration, right? Which I think nobody knows the full answer to that. But a lot of the trials that we do participate in are sponsored trials by private industry, and so those continue to be supported. Obviously, the main issue that we foresee will be with NIH funding and these sorts of things. And so I will say that while Cornell has been really proactive in trying to deal with this, so far labs have remained open and focused on research in both IBD and other areas. And so obviously, the medical and research communities are very resilient. So definitely trying to be optimistic that everything that we would like to do will be preserved within this climate. Okay, so
If I can add to that, the Crohn's and Colitis Foundation also supports quite a bit of research. So that the, I don't think the government yet has control over those funds. So it's another avenue that we look very that we work with quite often.
perfect. Yes. Thank you for adding that. So there are a lot of different questions here, so I'm trying to pick the most applicable. I guess first, maybe Randy, can you comment on any data for the use of probiotics or prebiotics in IBD?
Sure. I think some of the strongest data that we had, for probiotics probably comes more from the ulcerative colitis literature. And so these are some earlier studies looking primarily at patient cohorts of patients with ulcerative colitis who were on mesalamine therapy that were not optimized. And in this situation, some of the studies showed that using a type of probiotic, which at that time was called VSL3 and has now morphed into different formulations, were effective in restoring healing. And I think it's from some of that early data that started a lot of enthusiasm for many of the trials which you've probably heard about for fecal transplant with ulcerative colitis. And so there's been probably a dozen or so randomized controlled trials, including one that we recently finished here for fecal transplant for ulcerative colitis. And those studies, while variable, show that overall there seems to be a beneficial effect for fecal transplant for the treatment of moderate ulcerative colitis. Now, the key here is that we don't know exactly which bacteria those are. And obviously, that would be very important so that the appropriate cocktail could then be manufactured. And now there are several companies who have started to look at that. One that continues to remain active is called Vedanta. And this is a company that is currently in the process of evaluating that therapy and a therapy that we've participated in as well. We have recently also completed a trial to understand whether or not prebiotic supplementation can increase the potency of the bacteria that exist within the gut. And so this was conducted in patients, again, with ulcerative colitis, where a fiber supplementation was used to sort of promote the healthy bacteria. And this was very helpful in identifying what some of those bacteria are and how we can tune them with different dietary intervention. For Crohn's disease, even though there are certainly changes in the microbiome that are associated with Crohn's disease, and antibiotics in some situations are helpful for inflammatory ileal disease, we have less data showing that probiotics are helpful in Crohn's disease. And this has been a conundrum, for the field, actually, why we don't have better probiotic approaches for Crohn's disease. We are currently working in a national study in collaboration with colleagues from University of Minnesota to study a capsule-based probiotic for Crohn's disease. And this is a capsule that either has a coating that is releasing in the small intestine or releases in the colon to determine what is the appropriate encapsulation for delivery. And so the idea here is maybe we have not delivered the bacteria to the right place for Crohn's disease. And so this, these studies are currently for Crohn's disease at the level of trying to understand mechanistically what do we need to do better in order to make this therapy more effective for Crohn's disease. So hopefully that gives some perspective, Dr. Lucan.
Yeah, really great.
If I
Thorough.
can add, if I can add something from the surgeon point of view, I see the future as us being able to actually rebalance the microbiome in the intestine of patients with inflammatory bowel disease. So I see that at some point we will have personalized approach to rebalancing the microbiome to the specific individual based on the location of disease, in Crohn's disease, extent of disease, and so on and so forth. I mean, the field of microbiome science is it's very exciting, very it's growing very rapidly, and I see that becoming the future in the next few years.
Great. I'm going to start to answer this question and then turn it back to you, Alessandro. Sorry, there's a printer going off in the background. But it is regarding stricturing Crohn's disease. So this is, causing a narrowing in the small intestine or the colon, and traditionally is something that was it causes a lot of symptoms, including abdominal distension, bloating, as well as abdominal pain. And many patients avoid eating because of it. Are we having better diagnostic techniques to identify stricturing disease? I believe the person who wrote the question is referring to the difficulty of the diagnostic testing of the MRI or CAT scan or small bowel series that are very difficult for patients to undergo. And are there any clinical trials for medicines that are starting to look into this? And so I will say, number one, yes, there are clinical trials. We actually had started a trial, unfortunately, that was closed a little earlier than we had hoped. That was the first one that started to look into a new mechanism of action that was effective in some other conditions for stricturing Crohn's disease. But there are several trials that are now just about underway that will start to look into new therapeutics that could potentially reverse fibrosis in Crohn's disease and strictures. Secondly, we have now brought intestinal ultrasound into our clinic. And so we're able to, at the point of care, during an office visit, offer an intestinal ultrasound where we can put an ultrasound probe on the belly and look at the entire bowel for narrowing, dilation, and strictures without having to do all of the difficulty for an MRI. And so I think that this allows us to much more quickly and less painfully get the answer to whether or not a stricture is present. And two of our providers, Dr. Sayoun and Dr. Claytor, have specifically trained in intestinal ultrasound and are doing this on a daily basis when they're in clinic with us. And so I think that that's a great resource to have. And many societies have started to incorporate this into their guidelines. And many of the clinical trials will start to also look at outcomes based on how the the intestinal ultrasound, sorry, not endoscopic ultrasound, intestinal ultrasound appearance, changes over the course of therapy. I think that also dovetails very nicely with some of the minimally invasive techniques that Dr. Fischera can explain about how we're able to treat stricturing Crohn's disease.
Great, no, great question. And stricturing Crohn's disease is another one of our, from the surgical side, of the difficult aspects of Crohn's that we manage. Now, there are two components to a stricture, right? There is the fibrosis, the scar tissue that causes the stenosis, but oftentimes there is inflammation on top of that that makes the narrow even more significant, even more debilitating. And that's when the gastroenterologists and the surgeons work together, right? We get great information from MRIs and now with ultrasounds on the amount of inflammation that is creating more of a stenosis than just a scar tissue. And the preoperative optimization by treating that inflammation to make a smaller operation possible is what is part of our working together. So when patients come with obstructive symptoms with a step with a blockage, distension, and cramping, we do image patients, and now with ultrasound, it's fantastic. It gives very detailed information on fibrosis and inflammation, or with MR enterography to see if indeed we can optimize this patient to the point that we will be operating on, if indicated, on just scar tissue and in a short stricture with just scar tissue, not inflammation. A stricturoplasty would be the preferred option. It preserves intestinal length, of course, relieves the symptoms immediately, and interestingly, believe it or not, if there is a recurrence of disease, is very rarely at the site of the stricturoplasty. So the stricturoplasty, in a way, sort of cures the disease in that specific location. Now, patients with multiple strictures may recur somewhere else after a stricturoplasty, but it's very rare to have a recurrence at the stricturoplasty site. So potentially, that's a way to not potentially, definitely a way to preserve intestinal continuity, avoid a resection, and provide the patient with symptomatic relief very quickly and in a durable fashion.
Great. And I think another person had a similar question that sort of is on a topic related to this, is that is surgery the only way we can deal with a stricture? And in addition to those strictureplasties or minimally invasive types of surgical procedures, endoscopically, if we're able to reach it with a colonoscopy, we can often try strategies like dilation with a balloon, or sometimes even to use an endoscopic technique to sort of break the stricture if it's amenable endoscopically, although that is a specialized procedure that can be done endoscopically. So yeah, definitely one of our biggest challenges, I would say, is the management of stricturing disease, and certainly we do hope that some of these new medical advances will also be able to not only prevent the development of future strictures, but also to reverse what we currently call permanent or irreversible damage that strictures are causing to patients. So hopefully they will be able to actually turn back time, which would be very nice.
And Dr. Lucan, if I can extend that as well. I mean, um, as you know, our evolving data for Crohn's disease is suggesting that treating earlier is the way to go. To prevent disease progression, as you so nicely showed in those diagrams. But even sometimes, if the medicine is effective, such as Remicade for the treatment of ileal disease, there still can be stricture formation in the need for surgery. And so having these new medicines that could potentially block or reverse that type of fibrotic disease, I think is really key. And one of those medicines that's currently being developed is blocking a molecule called TL1A. And this is being investigated by a couple companies to treat Crohn's disease, and something that we've partnered with some of those companies to evaluate for Crohn's disease. And so I think that that'll be also really exciting to see if these newer therapies can actually block that progression of fibrosis, which currently we, as you mentioned, we have no therapies for fibrotic disease in Crohn's disease.
Yeah. So thank you to both other panelists, because I think really three different sort of takes or complementary takes on structuring Crohn's disease. I do have a number of questions about specific therapies, which again I would just remind you, just in this forum, probably don't have the time to address specifically. But one person did ask about combinations of therapies that are currently available. So when is combining more than one therapy uh, applicable? When should we think about doing this? And the example and the question is an IL-23 with a TNF antagonist. Either.
Yeah, so no, I think it's a great question, and this is really cutting edge in where people are thinking. As you know, it's not currently approved, to be able to use two therapies for the same indication. But I think one of the clear areas where we've started to learn from this is if there's two indications, right? We know that Crohn's disease and to a certain extent ulcerative colitis can be systemic, can have systemic inflammation. So there can be arthritis, there can be skin inflammation, there can be psoriasis associated with some of these intestinal symptoms. And so in that situation, this extraintestinal manifestation, as it were, reveals to us some of the biology about how this is happening. And so in that situation, maybe we would use an IL-23 blockade to help with the psoriasis and anti-TNF alpha to block some of the inflammation, or Remicade to block some of the inflammation that's in the intestine. Similarly, also, we've had the development of new small molecules, such as a medicine called Rinvoq, which can really hit the main signaling pathways and a lot of the inflammation going on. So sometimes one medicine is able to really tackle, many of these pathways. There are several trials that are currently ongoing that we're looking forward to. We've seen what's called the phase 2 responses, so the early clinical trials for the combination, particularly of IL-23 medicines with anti-TNF alpha blockade medicines. And so I think that this is certainly on the near-term horizon. Many of us feel that there is going to be approval for using some of these medicines in combination, should they show efficacy in a broader cohort. So I think for my practice, combination therapy is certainly effective when there's extra intestinal manifestations going on, and that reveals a different type of phenotype, or the severity of disease and in trying to get control of intestinal disease, such as fistulizing disease, as we've talked about. But I think for the broader context, we're going to see this emerging, as it comes to these clinical trials, particularly since the emerging data suggests to us that the stronger we treat Crohn's disease early, the better outcomes, the better we'll be able to prevent the progression of disease. And so I think that this is certainly something to keep an eye on over the next couple of years.
Yes, this is currently off-label, but we do hope there will be FDA-approved options, and certainly something that we do think about on an individualized basis. That chat message was just to remind you that we are approaching the hour. I'm just going to take a stab very quickly a question, because someone did ask about microscopic colitis or collagenous colitis, which is actually a subtype of inflammatory bowel disease, typically without the rectal bleeding, and no visible endoscopic changes, but definitely something that causes a lot of symptoms. And the question was about whether there are therapies available, some of the medicines that we're talking about. There are no randomized clinical trials. There's a lot of real-world evidence with some of the advanced therapies, including the biologics and immune modulators, that do suggest that they work similarly well for microscopic colitis as well. In microscopic colitis, we do try to think of other medicines that might be contributing, like NSAIDs, such as ibuprofen, or a proton pump inhibitor like omeprazole, and trying to remove those, or cigarette smoking. And if those things are not working and conventional therapies are not working, we certainly do consider the use of advanced therapies in our center. So, and there are many, many more questions that I couldn't get to, and I thank the audience and the panelists for your very wide-ranging questions. I'm glad that we're able to answer many of them, and I do apologize to the other attendees that we weren't able to get to. But for my panelists, I really thank you for some great insights. For the attendees, I really thank you for spending an hour of your afternoon with us. And as you can see, we have a very multidisciplinary approach at Cornell, and we really feel that it is a great environment to to help patients with many different phenotypes and presentations of disease. Thank you very much, and we will give you back your evening.
Thank you.